Thank you very much for the nice introduction. It's my pleasure to be here today with you all talking about a very important disease, which is Wilson's disease. I do acknowledge that none of you are probably a hepatologist, so I will try to share with you important information about Wilson's disease that's of interest to the practicing genetic and metabolic specialist or general pediatrician. So, over the coming 20 minutes, I will talk about the background of Wilson's disease. Then I will talk briefly about the important diagnostic tests for the non-hepatologist, and I will highlight on the treatment principles. So, as we all agree, Wilson's disease is a genetic disease. When Dr. Ayman approached me earlier, he said, let's talk about a rare disease. Actually, Wilson's disease is not a rare disease. It's estimated that 90% of the people carry the mutation for the disease, and the disease prevalence is 1 in 30,000 people. So it's not a rare disease. Probably it's underdiagnosed in many of the patients. In summary, Wilson's disease is characterized by accumulation of copper in different body organs. Liver is one of them, the brain, and also the eyes, the kidneys, and the heart, and so on and so forth. Copper is important for many factors and enzymes in the body. It's present in almost all kinds of food. Most of us, we eat too much copper in our diet daily, but we depend on our liver to excrete it in the bile and go on the stool. The defect in Wilson's disease is that the liver cannot get rid of the copper. So the copper stays in the liver and then it overflows all over the body. That's an oversimplification of the pathogenesis of Wilson's disease. All right? So it's estimated that we eat 1 to 2 milligrams per day, and probably we need only 10% of that, 0.75 milligrams of that, half of that, I'm sorry. Wilson's disease was described back in the 1700s. However, the specific diagnosis was about 100 years ago. And if you look at the x-axis, it's the years and the development of the disease. Penicillin was introduced in the 1950s. Then Trientine is about 40 years ago. And 30 years ago, we have the genetic diagnosis of Wilson's disease that makes the biggest change in the management of this disease. Okay, I can skip this. So, the main presentations of patients with Wilson's disease is either hepatic or neuropsychiatric. In the hepatic, it can be anything. Anything from increasing liver enzymes to jaundice, acute fulminant hepatitis, chronic liver disease, subtle liver disease, anything. So the message from this slide from the liver disease, anybody after the age of 1 year with any liver disease, he should be screened for Wilson's disease because it's a common and it's a non-specific disease. Anything after the age of 1, liver disease, Wilson should be screened at. The neuropsychiatric is a bit interesting because they come with a fairly specific ones, the dysarthria, the dysphagia, being clumsy and being having incoordination. They do not have a sensory or muscle weakness. Usually their sensations are intact and their muscles are intact as well. So any liver disease, but a specific neurological disease. We have some patients who come with mixed, and we have 11% who are probably asymptomatic, and I guess this percentage should be increased with screening for these patients. Some of the rare manifestations is patients come with outside the liver and the brain, like hemolytic disease, kidney disease. I have picked at least a couple of patients who come with quote-unquote autoimmune hemolytic anemia, turn out to be that they have Wilson's disease. This is the famous KF ring. You can appreciate a brownish discoloration at the outer side of the iris. You have to ask your ophthalmologist to look for that. However, in children, that's extra super rare. If it happens in the untreated adult patient. The NAS began and the S began, the American and the European societies, they said any sign of liver disease, they should be screened for Wilson's disease. All right, moving on to the diagnostic tests that we have available for patients with Wilson's disease. Different societies have talked about different criteria to do that. The one I like is the last one from the European Society, which says clinical and biological, and I think they should add the genetic testing as well. Serum seroplasmin. I will leave you with one word. If the serum seroplasmin is above 20, it's very unlikely your patient have Wilson's disease. If it is less than 20, this is probably abnormal, and there is a chance that your patient might have Wilson's disease. And I think this is a good number to remember. Most of the labs, their normal is 17 and above, but I think 20 is an appropriate cutoff point, and I will show you some studies to that. This is what's called the Leipzig score. It's a scoring system looking at different manifestations like the KF ring, the neurological, the serum seroplasmin, and hemolytic anemia is one of them, liver biopsy, urine copper, and so on and so forth. But I think for you, this is the most important. If you have a mutation analysis, that will give you probably the best diagnostic criteria. Did I emphasize the importance of screening everybody? Anybody with any liver disease after the age of 1, please do a seroplasmin. In this study, they looked at patients with 2 cutoff points, less than 14 and less than 20. If it's less than 14, the sensitivity is more than 90%, and it's very specific. It's almost 100% specificity. If you use less than 20, 90%, 95% sensitive, 85% specific. Not to miss any cases, again, anything less than 20 should open your eyes to look for Wilson's disease. Of course, it can be falsely increased with any liver disease, pregnant women, ladies who are taking oral contraceptives, different techniques, so on and so forth. So it's not a 100% test, but it's a fairly helpful test. When I see a patient with low seroplasmin, 3 differential diagnoses come to mind. Number 1 is Wilson's disease, and that's probably the most common. The second one is glycosylation defect. So I will send this patient to one of you guys to look at that. And the last one is hereditary A seroplasminemia. This is a super rare disease, and they don't come with copper disease. Actually, they come with iron overload syndrome, which is totally different manifestations. The others are less likely. All right, you can skip this one. Just to put the whole picture together, the total serum copper equals the copper attached the seroplasmin and the free. So in Wilson's disease, since your seroplasmin is low, your free will be normal, so the total will be less than normal. Just to understand how the mechanism of the disease. Okay. The 24-hour urine copper test is a helpful test, and we asked our patient to collect their urine for 24 hours, and then we look for the total amount of copper in the urine. Normally, we should excrete less than 40 micrograms. However, if it's more than 100, this is typical of Wilson's disease. This is a send-out test. Make sure they collect the urine in the right bottles, which is acid-washed bottle, because of the risk of contamination. Liver biopsy, many of these patients, they will require liver biopsy for diagnostic and also to assess the severity of the disease. And if it has too much copper, more than 250, this is suggestive of Wilson's disease. However, it's not specific, as many liver disorders can present with copper overload. Mutation analysis. You have to teach me, because I was told this is a monogenic disease. I thought in my mind that 100% they should have the mutation, but I came to learn that 95% they have the mutation. In my practice, I have one patient who has typical Wilson's disease and the mutation analysis is negative. They tried to explain it to me, but I'm not a genetic specialist, so I did not really get it. But they told me 5% they can have a negative mutation, but they still have the disease. All right. When you diagnose patients with Wilson, unfortunately, many times it's an advanced disease. But that's not the most important thing. The most important thing is to screen the family. As we all agree, this is an autosomal recessive disease, so there is a 25% chance that somebody else in the family has it. And so when you diagnose somebody, we screen the rest of the family, and that's the beauty of the disease. If you screen somebody and you diagnose them in the pre-symptomatic stage, you can almost reverse the disease and they can have a normal life and normal quality of life and a normal outcome. So please don't stop when you diagnose somebody with Wilson's disease. The screening, different societies, they have different screening method. If you work in UAE or in a country with rich resources, I think the best thing is to do the mutation, genetic mutation, directed genetic mutation to the first degree relatives, the siblings, the father, and the mother as well. If you don't have that much luxury of money, at least you can do seroplasmin, liver profile, and so on and so forth. Treatment. The treatment first is the diet. We restrict them from eating copper. Copper-rich food includes the yummy foods like seafoods, nuts, chocolate, mushroom, and so on and so forth. Come on, if somebody tells me don't eat chocolate, I will hate that doctor. I mean, we all hate that. So the societies, they say at the beginning, restrict the food. However, after successful treatment and you bring the liver enzymes down, you can allow them to eat copper-containing food. However, not to be too excessive in that amount. And with the new therapies, you still can eat copper-rich food and do a good job. The medications in general, we have two groups of medications, the chelating agents and the blocking the absorption agents. The chelating agents, we have the D-penicillamine and the triantine. And what they do, they chelate the copper and made it to be excreted in the kidneys. As simple as that. So you take it with your, away from your medication, it sucks the copper and get rid of it in the urine. As you can probably understand, since it's going to go through the kidneys, one of the side effects is renal injury. The other group of medication is blocking the absorption, which prevents the absorption of copper from the GI tract. That includes the medications, the zinc salts. There are different preparations of zinc. The best one of all is probably the zinc acetate. I'm not going to bore you with the details of the treatment, but in general, what we do, we start with the two medications, the chelating agent and the blocking the absorption ones. However, after successful decopperization of the body, probably you can live with only the zinc. Zinc is a very benign medication with much less side effects. All right, I think I can skip this for the end. And the other thing, if you diagnose somebody pre-symptomatic, you can treat them with zinc alone, and that probably will prevent the development of the Wilson's disease. And really, I feel great when I see I diagnose somebody at the age of 2 or 3, pre-symptomatic, give them zinc alone, and they have a normal liver and a normal outcome. It makes my day. Okay, we talked about it. Penicillamine versus triantine. Triantine is probably the better option. It has less side effects, specifically less neurological side effects and less kidney side effects. However, triantine is much more expensive than penicillamine. All right, these are details I think we can skip. All right, okay. Okay. So if somebody has a kidney disease or a neurological disease, probably trientine has advantage over D-penicillamine. So, Mr. Chairman, I'd like to concluding that Wilson's disease is not a rare disease. However, it comes with variable clinical manifestations, mostly any liver disease or neuropsychiatric disorder. The test, please do serum ceraplasmin whenever you see anybody with any liver disease or in the first degree relatives in these patients. If you want to do more sophisticated testing like urine, copper, or liver biopsy, we'll be happy to help you with that. Treatment includes the chelating agents like penicillamine and trientine. Also, you can use zinc to decrease the absorption of copper. It's a lifelong disease, and it depends on what stage you diagnose the patient. Thank you very much. I'll be happy to take questions, and I think I finished before time. Thank you.